Thank you for the very kind introduction and very good afternoon to all of you. It's a pleasure to be here this afternoon and to enjoy the warm hospitality that has been extended by Dr. Biniraj and All About Implants team here. Kochi holds a very special spot in my heart because I was here in 2012 with my son when he captained the Tamil Nadu team, table tennis team at the Nationals, which was held here in Kochi. And they won the cup and came back home, so it holds a very special spot for me. And whenever I've been in Kochi, it's been a very warm and welcoming experience, so I have great memories here. And I hope this particular trip also I'm going to take back home a lot of warmth and a lot of love from Kochi. I'm from Chennai. I'm a hardcore Chennaiite, so vanakkam to all of you. And there are a lot of things I feel that are common between Chennai and Kochi. One being the weather. Fortunately, for the first time in my life, I can very safely say that Chennai is a little cooler than Kochi today. But otherwise, we take the cake always. And the other thing I think that Chennai and Kochi hold in common is that we're all a little slower in catching up to new trends. Not that it's a negative thing, but I think both the cities are very much culturally grounded and take their time to catch up to new trends instead of running to be there and catch up with new trends. So very culturally rich cities. So I'm happy, I'm a proud Chennaiite. So that's me, a brief introduction. That's my practice, and I have a two-chair practice, and I predominantly practice implants and perio and lasers. And I have been an academician for 14 years. I voluntarily resigned in 2019 to get into complete private practice. But I'm not completely out of teaching because of the love for teaching and the love to be around students. We still continue to run a training academy in Chennai. Me and my colleague, Dr. Senthilnathan, who is a prosthodontist, both of us have been mentored by Dr. Muniratnam Naidu. I think he needs no introduction at all. He's one of the icons of dentistry, at least in the South, he's well recognized. So we run our own training academy where we train dentists in implant dentistry, soft tissue, hard tissue management, laser dentistry, etc. So that's our academy that keeps our academic side still glowing. And I also have lead a group of women implantologists in Chennai called the Women Implantology Network. So it'd be nice to have a network like that in Kochi also. So if there's anybody, any woman implantologists who would like to come forward and take the lead, we could form a team here also. We meet once in 3 months and we catch up on literature reviews, cases, etc. So that's what Women Implantology Network is all about. So I think that's a lot just in terms of introduction. So implantology, the practice has evolved a lot. So with those of us who started practicing implants about in the early 2000s, about 2 decades ago, from then to now, implantology has really moved in leaps and bounds. So it's not only in terms of technology that implantology has changed a lot. The main thing is the evolution has been on the side of the expectation from patients. So even patients now walk in asking for implants, asking for a particular system of implants that they want placed, asking for a particular technique. So when we extract teeth, patients actually come and say, can you put a bone graft inside? So there's that much of awareness going around. So there is a lot of evolution, not only from the clinician's aspect and from the science of implantology, but evolution in terms of the patients that are also reaching out to us. So yesterday I had a patient who walked in who was from Canada, and she walked in, she had a missing tooth. She was a 72-year-old, but she wanted an implant placed immediately. So she comes to me and she says, I have seen videos where you can place an implant and give me a crown immediately. So can you do that for me today because I'm flying out tomorrow morning? So is it possible? I think the truth is, today it's possible. We can deliver it, but there are many aspects which will, dictate whether it's possible in one particular case or not. So this is one such case here in the video that we have presented. A patient walks in, and the choice was to either extract, give a denture or a bridge, or do an extraction, wait for a period of time, place an implant, or do it immediately. Since it was an anterior implant, we decided to go ahead immediately, extract, do an immediate implant placement. So that's the implant placed immediately after extraction in the socket. And the abutment given. And it was temporized immediately. So the patient walks in like that, and the patient walks out like that in a matter of an hour or so. So this tooth in an hour concept is something which is catching on with patients also. So they want immediate results. They want something that they can visualize. So is it possible to deliver this? It is, this day and age, definitely it's possible. So in this presentation, we'll discuss the following things. We'll briefly touch upon osseointegration because this is more of a theoretical concept, so I don't want to get too much into details. I'll give you the basics which are actually applicable to the clinical aspects for us. And then we'll look at the timing of implant placement, the loading of dental implants, and we'll discuss a few cases thereon. So a predictable journey from extraction to restoration. You can take a look in these cases that I've presented here, the preoperative and postoperative. A predictable restoration is possible in implants if and only if you pay attention to certain things. Now, osseointegration is a microscopic level concept, and it's not something which is clinically relevant, or that is what we tend to think. But osseointegration is what ultimately gives you the stability that you need, which will help you load the implant, right? So understanding osseointegration and the clinical options for predictable outcomes in a less amount of time is what we need to achieve as clinicians. So this person needs no introduction at all. He's probably, I would say, the person who has revolutionized dentistry in this entire century. I would say that the term osseointegration that he has coined after the discovery of osseointegration has been a game changer for dentistry over this entire century and more centuries to come, I guess. So he has defined osseointegration as a direct structural and functional connection between ordered living bone and the surface of a load-bearing implant. Now, this is a very theoretical sort of a definition that we are looking at, right? So how is this clinically relevant to us? So if you break down this and look at osseointegration from this viewpoint of what is projected on this slide, what basically it says is osseointegration is a time-dependent healing process. Yes, because it has certain stages and it goes through a time period for it to completely develop, which can be achieved and maintained only and if only you get primary stability at the initial stage. And finally, when the osseointegration is complete, you should have such a stable interface that it can carry loads for the lifetime of the implant. So this makes more clinical relevant statements to us. An osseointegration has to be time dependent, and the initial or the primary stability that you achieve as a clinician will dictate how well the implant osseointegrates, which finally dictates how much of load it can take because it ends up having a particular amount of secondary stability, which is necessary for the long-term success of the implant. So this basically gives you a more clearer understanding or a clearer definition, clinically relevant definition of osseointegration. So there are some factors which affect osseointegration, and the factors, some of them are relevant to us, some are not under our control. So if you look at this, the first three factors which are listed here are the biomaterials for dental implants, the surface composition, and the implant design. Now, these three factors are not totally under our control, right? So you as a clinician are not going to make an implant, design an implant, manufacture an implant. You're going to procure an implant from a particular system. So what can you do? Okay, what biomaterial is good? Yes, commercially pure titanium, titanium alloy, and these days you have zirconia also. And there are studies which show that zirconia also has as good osseointegration as titanium and titanium alloy. So that is also a good way to go. So the biomaterial is always clear. It's either titanium or titanium alloy. The composition, surface composition, it's anything which has micro roughness on it, works well for osseointegration because of the way it attracts osteoblasts, migration, and proliferation on the surface. So sandblasted, acid etched, plasma sprayed, anything is fine as long as there is a rough surface for us to work on. And finally, the implant design. So active threads have shown to be better for osseointegration compared to threads which are square shaped. So these three factors are not under your control, but these three factors also play a key role in osseointegration. So as a clinician, before you pick a particular system, the driving force or the decision maker should not be the cost of the implant, how many implants, what kind of a deal I'm getting from the dealer. Of course, economics is important. We're all in here for it, for our bread and butter. I'm not saying no. But there is some level of intelligence that as clinicians, we have to exhibit before we select a particular implant system for our patients. So look at a system which has a long presence in the market, a system which will continue to stay years afterwards, and a system which will work well for your practice as well. Companies which put in a lot of research and development into their products are what you need to look at. So find an ideal implant system that works for you. The next three factors are completely under our control. There is no excuse for slacking off on these. So the heat that is produced during the surgery, any contamination, and finally the primary stability that you achieve when you place an implant are the three key factors that you as a clinician can absolutely control. So heat, of course, during your drilling procedure, you need to be careful with copious cold saline irrigation, and practice the intermittent drilling so that there is not excessive heat produced leading to bone necrosis. Next is the contamination. Avoid touching the implant with gloves, dropping the implant and then replacing it. So very basic, whatever common sense dictates is what contamination means. And primary stability, you need to achieve a proper primary stability. A minimum of 30 to 35 Newton centimeters is what is necessary for you to go forward with a proper implant procedure. Finally, the last ones are the bone quality and the loading. Now, the bone quality, again, you have no control over, but you can modify your surgical protocol so that you can manage poor quality bone also. For example, whenever you have poor quality bone, you can think of osteodensification. Dr. Lalit was talking about it this afternoon. And osteodensification is a great way for you to increase the bone quality, even in poor quality bone. And also, the loading will be dictated by how much of primary stability that you have achieved. So these are the factors which will influence osseointegration in the long run. So this is just a brief picture which summarizes the surgical aspects that you need to pay attention to in order to get a good osseointegration. So profuse irrigation during drilling, cooling during the drilling procedure, intermittent drilling, speeds not to exceed 2000 RPM, and if you're hand ratcheting, stay at 15 Newton centimeters. And gradual enlargement, instead of jumping drills, go to a gradual enlargement of the site. So these are the things that you pay attention to as far as your surgical protocol goes. Now moving on to timing of implant placement. If you notice the osseointegration, the stages that it goes through, there are two stages that osseointegration goes through. Stage 1 and stage 2. Stage 1 and 2 fall under surface remodeling, wherein there is a woven bone formation that happens first, and then the woven bone is slowly compacted into lamella bone. Now all this happens between 0 to 18 weeks, so which is 0 to about 4 months. This happens, 4 to 4.5 months. And after that, you have the remodeling of the surface and the maturation of that surface, which goes on for forever after that. So at what stage would you like to place an implant in a socket? So first, we'll talk about the timing of implant placement. So according to the ITI consensus statement, the placement of implants, the timing of placement of implants can be either type 1, type 2, type 3, or type 4. So type 1 placement is immediate, which means as soon as you extract the tooth, you're placing the implant in the socket. So there's no time gap between extraction and placement. Type 2 is early placement, where you extract, wait for about 4 to 8 weeks, and then place the implant. Now, why 4 to 8 weeks and why not immediately? Because there doesn't seem to be much of a difference between type 1 and type 2. Because if you look at the previous slide, within 4 to 6 weeks, nothing much is changing in terms of the socket, right? There is still woven bone formation only happening. So why do I wait for 4 to 6 weeks, and why is that given a separate classification of type 2? The reason being, most of the times, the difficulty that is encountered by most practitioners here, I'm sure all of you would have experienced it, is the soft tissue closure that is necessary, which most of us struggle with in immediate implant placements, especially in the posteriors, right? In the upper first molars, lower first molars, getting enough play from the soft tissue to get tension-free suturing and closure becomes a little difficult, especially because in immediate implant placement, you are dealing with grafts, you're dealing with membranes, so you want a proper closure to happen. So if that is not happening, then again, there is room for some failure to happen. So that is the reason why type 2 is favored by many, because at this time period, the soft tissue healing is complete. So you have a little bit of extra soft tissue for you to play with. So you can elevate a flap, do the procedure, close the flap without much of a stress about handling the soft tissues. Next is type 3, which is a delayed placement. At 3 months, where you've done the extraction, the socket is completely healed, and now you can go ahead comfortably with the placement. And type 4 is a fully healed site. After many years, you're placing an implant, so that falls under type 4. So these are the timings of implant placement as relevant to the healing of the socket and osseointegration. So what are the things that you need to consider if, for example, you decided to go for an immediate implant placement? So there are certain things that you need to keep in mind before you decide this case is okay for an immediate implant placement. So the first one is the presence or absence of local infection at the site. So how does local infection play a role? Now, for example, in this case, you can see the infection at the site. Now, will this be a case where you would prefer to go for an immediate implant placement? Probably not, would be my clinical judgment. There might be a lot of you out here who are confident enough to get rid of that infection and place an implant. That's fine too, because it's a very clinically sensitive judgment, and I need not confer with you and you need not confer with me. So if I'm not confident that it can be done, see? So I do get different opinions. As far as I'm concerned, I wouldn't do it. But he's confident to get the infection out, so that's perfect. So if you're fine to confidently get rid of the infection and place an implant, that's a wonderful option to go ahead. So my take is, if there is an infection there, and if the infection is well rounded, and if it is smaller in nature, and you're able to completely get it out, you can totally go ahead and place an implant and graft it. If it is a more diffuse sort of an infection, where you know you cannot get the entire infection out in one bit, then I would be a little wary of placing implants in a situation like that, okay? But again, it's a very clinician-driven decision. Like for example, diabetes, right? HbA1c, I would not go beyond a 5.5 or a 6, but there might be someone who would say 6.57 is okay. And both of us may be right. So it's just a very clinician-based thing that you need to look at. So the local infection presence or absence is one thing which you have to look at before you pick a case for immediate placement. Next thing is the amount of bone that is available above the apex of the extracted tooth. Now with immediate implant placement, the primary stability is achieved from the lingual or palatal plate and the 2 millimeters of bone beyond the socket of the existing tooth. Now when you don't have that, achieving adequate primary stability is going to be a challenge. So when anatomic structures are too close, that will be another red flag. So I wouldn't go ahead and place implants in a case where you don't have bone beyond the apex of the tooth. Next is the general health of the patient. Any situation that will affect bone healing, again, should raise a red flag. Why is that? Is because already you're looking at a situation that is compromised, on top of which you are doing an immediate implant placement where you have a bone graft placed, you have a membrane placed. So having a systemically compromised patient and having these other complications is not going to do a great deal in terms of the final prognosis of the patient. So diabetes, any vitamin D deficiency, poor oral hygiene, these should all raise a red flag in terms of selecting the patient for immediate placement. The next factor will be whether the extracted tooth is single tooth versus multi-rooted. Easier option would be a single rooted tooth, but multi-rooted tooth is not completely out of the window. If you have a multi-rooted tooth with divergent roots where you have a good amount of interradicular bone, that would be a great option to go for immediate implant placement. On the other hand, you have convergent roots, interradicular bone is very thin. Again, it's going to be a little difficult for you to engage that bone. So think of it as doing a thorough analysis of the site, even with cross-section CBCT, before you decide to go ahead with immediate implant placement for multi-rooted teeth. Key factors, especially important in the anterior aesthetic zone where you want to do immediate implant placement, is thickness of the labial bone. The problem with the labial bone is that it can resorb very easily, and in most cases, because of the morphology of the root itself, the labial plate was already be thin. So the socket will heal at the expense of the labial plate. So you will be losing some amount of the labial plate once the extraction is done and the healing is happening. So if you are not prepared for that, then immediate implant placement is going to be a failure, especially in the aesthetic zone, because once the labial plate starts resorbing, what follows is the soft tissue, right? So you end up in situations like that, where you would have started with the best of intentions to restore and give patient temporary restoration at least immediately, but you end up in a situation like this because the labial plate is thin and the soft tissue follows as soon as the labial plate starts resorbing. So the labial plate is next, and after that follows the nature of the soft tissue. Look for cases which have a thick periodontal biotype instead of a thin biotype, because that is going to be more conducive for you in terms of achieving final aesthetic outcome. So in terms of aesthetic outcomes, several studies and literature reviews have shown that based on many aesthetic indices that have been done in immediate implant placement in the anteriors, at least 80% of immediate implant sites demonstrate satisfactory outcomes. There is always a clause here that you do the right case selection, right? 80% of the time you will get satisfactory outcomes provided you do a proper case selection, keeping in mind all the above points that we have just discussed. So aesthetic outcomes, good aesthetic outcomes is possible with immediate placement as well. And maybe a decade and a half ago, immediate implant placement was considered a blasphemy. But right now, I think it's the way to go, and most clinicians are doing immediate implant placement without the fear of failure. That's because of the amount of confidence you have in your other augmentation procedures. So any immediate implant placement should be accompanied by soft tissue and hard tissue augmentation procedures. So keep that as a side note, because when you speak to your patient about implant placement, if it's immediate implant, then you also need to factor in the cost of the auxiliary procedures that you will be adding into this. Next is the time of loading of the implants. When can I load the implants? When is it ideal so that I don't end up in a mess later? Again, if you look at the osseointegration, stage 1, stage 2, stage 3, and stage 4, and then look at the loading protocol. The loading of implants, again, according to the ITI consensus statement, can be divided into 3 types. So type A is immediate. That is within 7 days. Within a week after implant placement, you will load the implant. Type B is early, wherein within 7 days to 2 months you load the implant. And type C is anytime after 2 months you will load the implant. So which would be the way for you to go? Which is the ideal situation, and how will you take it forward? So there are certain treatment modifiers which will help you make that decision. Can I load this implant immediately or not? So some of them are listed here. First of all is the patient's health. So the patient's health, again, anything that affects bone metabolism should be a red flag, because healing is going to be delayed, and thereby your loading can end up in adverse outcomes. So diabetes, vitamin D deficiency, again, will be key factors here. Other risk factors include smoking, oral hygiene, bruxism, and patient compliance. So any systemic condition or habit which is going to have an effect on the microvasculature and wound healing, again, will be a factor which will help you make a decision as to whether you want to load the implant also. Because only if you achieve primary stability, you can think of loading the implant. So the factors that affect your primary stability are also going to affect the timing of loading of your implant. The next thing is the dimension of the implant that you've used. So if you've used implants of less than 10 millimeter length and less than 3.5 millimeter diameter, it would be wiser to not load them immediately, because of the fact that the studies have shown that the implant dimension can be an important factor in failure of immediately loaded implants. Moving on to primary stability, how much of primary stability is necessary for you to load an implant immediately? So 35 Newton centimeters is the minimum that we need. And if you're using a resonance frequency analyzer, anything above 55 to 57 RFA reading will be a good point for you to think of loading an implant. Anything less than this, again, you should be a little wary of loading an implant immediately. The next factor is bone augmentation. If you have done extensive bone augmentation at a particular site, think of not loading this implant immediately. Again, because of the micro motion that is possible, the graft will not heal completely. So we want to avoid any kind of micro motion, so we avoid loading. So here are the factors that should be there if you want to think of loading an implant immediately. A healthy patient, no risk factors like smoking, a high insertion torque of greater than 30 Newton centimeters, minimal or no grafting, and an implant whose dimension is greater than 3.5 in diameter and greater than 10 millimeters in length. So these are the factors which have to be somewhat, fulfilled for you to think of loading the implant immediately. If most of these factors have not been fulfilled, do not go down the lane of immediate loading. Think of conventional loading, which is type C. So type A, you need to have all those things in place. So looking at putting together the timing of implant placement and the timing of loading of the implant, we'll quickly look at a few cases, and maybe if y'all would like, we can have an interactive session and y'all can give your inputs as to what you would like to do in a case like this. So here's the first case. Here's a case of a lateral incisor with periapical infection. Okay, so you can clearly see the infection in the radiograph, right? So any inputs as to what your approach would be first in terms of placement and then in terms of loading? So I would, obviously the lateral incisor to be extracted, okay? So here are the decisions to be made. One, when do I want to place the implant? Do you want to place it immediately or after 2 weeks or delayed? Now, what are the factors which help me make the decision? First thing that pushes me towards an immediate implant placement is that it is in the anterior aesthetic zone. So ideally, I would like to place an implant immediately so that I can load it immediately. But what for me raises a red flag is the infection, which is very diffuse. It's appearing very diffuse to me on the radiograph. So I wouldn't want to go down that lane. What other option do I have? If it is the posterior, I'm very happy to extract it and wait and let the patient come back after 3 months. But since it's the anterior, I just can't extract and let the patient go. So I decide to extract, give a temporary for a period of 2 months, wait for the site to heal, give a temporary because I would like the soft tissue to develop in the site before I go ahead with implant placement. Okay, so that's how it looks after the healing is complete. And we go ahead, drill, place the implant. And you see a few threads are exposed because that's the most ideal 3-dimensional positioning of the implant at the site. And we go ahead, give a periosteal release because we've given a slightly palatal incision. We grafted the site, then placed a membrane, and then sutured. Okay, so that's how it looks after the suturing is complete. And you can clearly see why. Could I have managed this case without a graft? Maybe if I had placed it slightly more palatally, I would have not exposed the threads. Yes, but yeah. I wouldn't want to do that because it will not be in an ideal 3-dimensional position for me. So I decided to go ahead and place it in the ideal position and use a graft thereafter. And you see how the graft has helped improve the site. I think we're talking about site development also. Dr. Lalith was talking about it this afternoon. So site development is key for placement in the anterior aesthetic zone. And from there, we end up in a situation like this. After 4 years, that's how the implant looks now. So there is still room for the papilla to grow, and it will take some time. Like most of you would know here, papilla reconstruction is not something that happens over a few years. It will take some time. But a good situation like this is possible. And the reason why we decided to go with type 3, which is delayed placement and delayed loading, is because of the infection that was there at the site. That was the key driving factor or decision maker for us in this particular case. Everything else was great. There was good thickness of the labial plate. The soft tissue is of a thick periodontal biotype, right? So all these factors were conducive except for the fact that I was not very confident about getting rid of the infection at the site. So that is why the decision of delayed placement and delayed loading was taken. Next is a case you see here. It's a fractured mobile crown in 2-1. And again, we have to decide the timing of implant placement and the timing of loading. So how we went forward here is to extract it, and we gave an immediate replacement with a bonded fiber reinforced composite tooth in order to maintain the soft tissue profile before we go ahead and place an implant there. So once that was done, that's the CBCT, how it looks with the temporary bonded composite restoration which was in place. It looks fine, except the not too happy about the volume of the bone that is present at the site. And then the patient comes back after 6 weeks, and we raise a flap, drill the site, place an implant, place a graft, and place a membrane. And that's how the implant looks. And we gave an immediate temporary, and then close the flap and suture it. So that's how the temporary looks. That's how the tissues look, immediate post-operative with the temporary in place. And this is after 2 weeks, after the tissues have somewhat healed. You see how it looks. Still not happy with the soft tissue profile there, because it's still, you can still see a dip on the central incisor. So we decided to go ahead, and at second stage we removed the temporary, and we decided to go for a connective tissue graft there to increase the soft tissue thickness. So elevated a flap, took a connective tissue graft from the tuberosity area, placed it, sutured. That's how it looks immediate post soft tissue grafting. And then that's the crown given. And now you can see this is how the temporary looked, and this is how the definitive restoration looks. So much better than the profile, the soft tissue profile that we had with just the temporary in place. So having hard tissue and soft tissue grafting as an auxiliary procedure is, it's no more auxiliary procedures. They've become necessities in most cases. So getting your skill sets ready in soft tissue and hard tissue augmentation is very key if you want to be a well-rounded implantologist. So here we ended up doing a type 2A, which means type 2 is anywhere between 6 to 8 weeks. So we took about 6 weeks later, we placed the implant, and we gave an immediate temporary restoration. So we loaded it immediately. So all the situation was ideal for us to load immediately. We got a good torque. There was not much extensive grafting done at the site. So it was ideal for immediate loading to be done. Plus it was conducive for us because it was an anterior aesthetic area. So we needed that immediate loading to be done. So this is the next case, incisors with a periapical lesion and retained deciduous tooth. There's multiple lesions happening here, multiple teeth had to be extracted. So that's how it looks. We had to extract all 3 teeth. That's the pre-op, and that's the pre-op radiograph. So off my head, this is not a case for immediate implant placement. The reason being, I'm seeing, malpositioning of the teeth and infected teeth, and it is one of the tooth is present here. So I'm going to have a very difficult defect for me to handle in terms of both hard tissue and soft tissue grafting. So this is not something I would want to go ahead with for immediate implant placement. So I'd rather do a delayed placement and a delayed loading. Let's see how that goes for us. So that's after extraction, and we've given a removable partial denture there during the 6 weeks. And 6 weeks later, the patient comes back, and that's how the ridge looks. Looks okay, but still the defect that is there needs to be taken care of. That's how the IOPA looks after 6 weeks. There is wormer bone formation, but there's not enough bone formation there, but that's okay for us because we just wanted the soft tissue to close. That's the CBCT evaluation that we did of the site. Went ahead, elevated a flap, incision, flap elevation is done. That's the stent in place, and the site is drilled, implants placed. So that's how the implant placement went. Excellent primary stability was achieved. Then always remember, whenever you graft bone, the first layer that goes on the surface of the implant should be your autogenous bone. So anything autogenous, it could be PRF, it could be PRP, it could be autogenous bone that you have harvested from the patient. Any of these is fine, but autogenous is what goes on first as the first surface. So once the autogenous bone is placed as the first layer, then you can use your allograft or alloplastic materials, whatever you prefer, on top of it to increase the volume. And then we placed a membrane, sutured the membrane in place, and then closed the flap and sutured it. So if you look at the final outcome after 3 months of placing the implant and grafting, that's how the site looks. So we compare how it looks pre and post. You can see how well the defect is taken care of. So this is more of an ideal situation for us to get a good emergence profile in the anterior aesthetic zone. So same thing happens here. So the defect is completely taken care of. A good grafting procedure, hard and soft tissue, can take care of most of your aesthetic issues. And that's a temporary which is given in order to develop the site. Because if you look here, the ridge looks almost flat. So if you go the same way and give a final restoration at the end, your soft tissue development is not going to be so great. So that's the reason we have temporized it at this stage. And next, we took a digital impression for this patient. And that's how the final definitive prosthesis looks. And that's how the final prosthesis looks in the patient's mouth. Patient has a low lip line, so the slight difference in the margin of the prosthesis didn't make much of a difference. And that's how the IOPs look. So you can look at the pre-op and post-op together there. That's how the pre-op looked, and that's how the final outcome of the case was. So here we did a type 3A, wherein we placed the implant delayed, but we gave a loading immediately so that we can develop the soft tissue for us to get a good final definitive prosthesis in place. And the next case is a lower second molar extracted 1 day back. The key driving decision maker here was the fact that the patient was leaving the country in 3 months. So we extracted the tooth, and that's the socket after extraction. And the patient came back after a month, and that's how the area looks. The soft tissue closure is complete. We went ahead and placed an implant, grafted the site. The patient came back after another month, and we took the impression and gave the definitive prosthesis. Now, this is one of the few cases where we've done an early loading. See, out of the 3 loading protocols, one is the immediate loading, the early loading, and delayed loading. We generally tend to move more towards immediate and delayed loading. Immediate non-functional loading and delayed functional loading is totally risk-free. Something like this is a definitive prosthesis which was given within 2 months of placement. Now, at the 2-month time point, generally your healing is at a phase where the lamellar bone formation is not complete for you to be confident enough to apply forces to even remove the healing collar. Because most of us sometimes, we tend to underestimate our hand torque strength, and we tend to overdo the torque, and sometimes it can end up in less than ideal situations if your osseointegration has not been complete. So there is a risk of that. So we generally tend towards an immediate loading in anteriors and a delayed loading in most cases, but it's one of the very few cases where we did an early loading at 2 months. Fortunately, we had good talk, and we had already decided that that was the way to go, so we kept all our checks and balances in place for the case. So in 3 months, by the time the patient left, the extraction, the placement, and the definitive prosthesis was delivered to the patient. So in this case, it was a type 2B sort of a situation. So type 2 is early placement between 6 to 8 weeks, and type B is early loading. So that's the way that case went. Finally, last case, where a second molar with a lesion the patient came with. Now again, this lesion is very large and very diffuse, so I wouldn't want to go for an immediate placement. So we extracted the tooth and allowed for it to heal without a socket preservation, because there was nothing for us to do there. So we decided to let it heal, and we were also unsure of whether we'll be able to achieve anything in this patient. But we continued to follow up this patient, and he came back after a few months, and that's the amount of bone that had formed without any bone graft. So that's the natural healing that has happened, and we were able to place a short implant at the site, a wide diameter short implant. That's how it looked, and that's how the final prosthesis turned up. So here we ended up with a type 4C, where it was a delayed placement and a delayed loading sort of a situation that we ended up with. So these cases just, we wanted to project the different scenarios, the different types of cases that you can, encounter in your practices. And no one decision, I would say, is right or wrong. So treatment planning is not only about, we generally restrict ourselves to treatment planning to decide what dimension of implant we need to place. But treatment planning should not only do that, but it also tell you what you need to do in terms of timing of placement, timing of loading. There are umpteen number of things that you need to take a decision about at the time of implant placement itself, and not restrict yourself to just selecting the dimension of the implant. So there is no right or wrong. You could go with the immediate, you could go with the early, you could go with the delayed, you could go with the immediate loading, you could go with delayed loading. But as a clinician, you should be able to take that call based on the treatment modifiers that are there. So whichever seems to weigh more for you, go that way. So better is to go in a low risk manner, because periodontics has always not been anybody's forte. So don't let the software tell you what is to be done. We as individuals have our own intelligence other than the artificial intelligence that is put out these days. So go with that and use your clinical judgment. This is a wonderful systematic review that is available. So you can check this out if you want more information on loading, placement, and how, how much of risk you can afford to take, what are the factors which will help you distribute those risks better for a better prognosis and outcome. So that is a good review article. Thank you all for your patient listening, and I'd like to thank my teachers, my students, and team all about implants here, and my patients and my entire team back home. Thank you.
Thank you, ma'am, for the extraordinary session on the science of osseointegration.